Hello, this is Dr. Benjamin Domb in what is perhaps one of the first presentations ever by an orthopedic surgeon at the American College of Obstetrics and Gynecology. And the subject of this particular lecture is postpartum hip pain, the prevention, the workup, and the management. And this is pearls and pitfalls from orthopedic hip specialists. So this first came to my attention because I had a patient who said, my mother-in-law tore my labrum. That was her presenting complaint in our clinic with hip pain. I said, what do you mean your mother-in-law tore your hip labrum? She says, well, I was giving birth and my mother-in-law tried to help me by pulling on my leg. And all I remember from giving birth is the pain in my hip. The pain in my hip was way worse than the pain of actually giving birth. And she was right. She had actually torn her labrum in her hip during delivery because her well-intentioned mother-in-law had twisted her leg in such a way that caused this hip injury, which ultimately required surgery. Unfortunately, we were able to get better with surgery. So this led me to an awareness of pregnancy and delivery-related hip injuries. And in fairly quick succession thereafter, I saw probably another dozen women who had had hip injuries in either pregnancy or delivery and had postpartum hip pain as a result. So that led us to publish what was perhaps one of the first articles ever published in the Journal of Obstetrics and Gynecology by orthopedic surgeons on acetabular labral tears and postpartum hip pain. And the intention of this article was to spread awareness in the obstetric community that this is a thing, that hip injuries can occur during pregnancy and delivery, and postpartum hip pain isn't always related to the vaginal aspects of the delivery. It can actually be an orthopedic injury, and recognize it can make a big difference in women's lives. So in this segment of the talk, I'm discussing what are the diagnoses, what should the OB look for and when to refer, what can we do, and how can we prevent these injuries. And we'll go over some of the causes of postpartum hip pain, which include piriformis syndrome and sciatica, labral tears in the hip, arthritis in the hip, pubic symphysis dysfunction, and then, of course, afterward, the hip carry. So piriformis syndrome and sciatica, the piriformis muscle goes into spasm, and sciatica can result because the piriformis crosses right over the sciatic nerve. And often this can be treated with physical therapy in the postpartum period by stretching the piriformis muscle and alleviating this pressure. When physical therapy is not enough, we can do targeted injections under ultrasound guidance, or in the worst of cases, surgical procedures to release tension on the piriformis. Femoroacetabular impingement is collision between a ball and socket that are mismatched in shape, and that can lead to damage to the labrum, which is the ring around the edge of the socket. Cam impingement is where the ball is out of round. Pincer impingement is where the socket is misshapen. Either way, there's this collision or friction between them, which causes labral tears. Here in this X-ray, you can see that the ball is not round. It's almost like the ice cream fell off the cone a little bit. And so if we have a ball and socket with a ball that's not round, it rubs against the socket, and that can cause injuries to the hips, such as a labral tear, especially with the positioning that occurs during delivery. So that brings us to the labral tear, which is probably the most common hip injury that occurs during pregnancy and delivery. The labrum is a cartilaginous structure. It's a ring around the edge of the socket. It helps form the suction seal that seals the ball in the socket and seals the lubricant fluid in the joint. And when it's torn, it can cause pain and mechanical symptoms or popping or locking. This can be a very painful condition, and it can result either from the pregnancy itself, when a woman gains weight and circulates relaxin and gets loose ligaments, or it can result from the actual delivery, as in the mother-in-law who tore her daughter-in-law's hip. So when we have these labral tears, it's important to recognize them, and if we do recognize them, we can treat them. Arthritic changes. Most women giving birth are on the younger side, but that doesn't mean they can't have arthritis. And the early parts of arthritis can cause a lot of inflexibility of the hip, loss of motion, and can cause pain. And this can be aggravated by either pregnancy or delivery. On the left, you see a normal hip. On the right, you see an arthritic hip where bone spurs develop, the cartilage is worn through, and this puts somebody at risk for injuring their hip during pregnancy or delivery. Here's an x-ray of an arthritic hip on both sides. The next entity is pubic symphysis dysfunction. So we all know what the pubic symphysis is. It's the joint in the middle of the pelvis. And during pregnancy, relaxin circulates through the body so that the ligaments can loosen up and the pubic symphysis can actually widen. The pelvis widens so that the birth canal can be wider and the delivery can happen. But this can cause instability and pain in the pubic symphysis. And sometimes that pubic symphysis dysfunction persists even after delivery. It's only diagnosed in about 1 in 300 pregnancies. The pubic symphysis diastasis occurs in 100% of women, though, and persistent pain in the pubic symphysis may be as common as 25%. So clearly, there are a lot of women with this problem who are not diagnosed, and this gives us a great opportunity to help women who otherwise might not find help. And lastly, there's the dreaded hip carry. So this can lead to lower back and hip pain and can basically aggravate all of the conditions we've talked about: labral tears, femoroacetabular impingement, arthritis in the hip, or pubic symphysis pain. So what the OB should look for. Firstly, by history, we're looking for pain lasting at least 6 weeks postpartum, and it's not improving with conservative treatments, including physical therapy or pelvic floor therapy, acupuncture perhaps in some cases, and activity modification. If they keep on having pain in their hip or in their pelvis, then we have to start to suspect an orthopedic issue. The pain characterization, the onset, the duration, and the birthing history can all be helpful. If a woman had an epidural, she may sustain an injury to her hip without even being aware of it during the actual delivery. How was she positioned during delivery? Who helped pull on her leg, if anyone? Did she have a difficult delivery? All of these things can contribute to the likelihood of a hip injury. And perhaps the most important slide of the whole talk for the obstetrician is this slide, which shows the Fader test or impingement test. And this is the most sensitive physical exam test for hip injuries. So if you have a woman who's got persistent hip pain, try this maneuver on her and see if it reproduces any of her hip pain. So Fader stands for flexion, adduction, and internal rotation. And if we do those 3 movements together, flexion, adduction, and internal rotation, in a lot of women with a labral tear or arthritis or impingement, this will reproduce the pain. It's not 100%, but it has a very high sensitivity, over 90% sensitive. When you refer the patient to a hip specialist, an orthopedic hip specialist, they will order specific x-rays. They'll order x-rays that can detect abnormalities of impingement, such as an AP of the pelvis, an AP supine and upright, a lateral Dunn view that shows us cam impingement where the ball is out of round, and a false profile view that shows us the morphology of the acetabulum or socket in the hip in a very specific way. They'll likely order an MR arthrogram, or at least they should, and the MR arthrogram will allow for better visualization of intra-articular structures. It's important to recognize that not all MRIs are created equal. And there are a lot of MRIs that get done, many of them without contrast, that don't give us adequate visualization of the hip. So you can go down a rabbit hole if you get a suboptimal MRI and it is read as normal, and then you think it's not a hip injury, when in fact the hip injury is there all along. It just didn't have adequate imaging. So very important to get a high resolution, at least 1.5 Tesla, MR arthrogram with contrast of the hip joint to see things like a labral tear. And in terms of when to refer to an orthopedic hip specialist, the first answer is anytime. Anytime there's suspicion for a hip or pelvic orthopedic injury, we welcome those patients at American Hip Institute. We see a lot of those patients. Sometimes we can rule in a hip or pelvis injury. Sometimes we can rule it out, and that's okay too. But never a problem to see a patient where there's a suspicion for a hip or pelvic injury. We can see them antepartum, so you may refer a patient who has a history of a labral tear or a history of pelvic trauma. You may refer them for a prepartum consultation, or postpartum if there's 6 weeks or more of pain that's not improving with conservative treatment options. At that point, it's time for a referral to an orthopedic hip specialist. In terms of prevention strategies, there are a number of ways that we can help prevent hip injuries. And the first is avoiding flexion with internal rotation. So when a woman is delivering, the well-meaning mother-in-law or anyone else can inadvertently injure her hip by flexing the hip up and internally rotating it. So we want to avoid that. And instead, we'll focus on flexion with external rotation. And it's important to discuss this with the family and other caregivers ahead of time. So basically, they can pull up on the thigh and pull the knee up and out, but never pull the lower leg or foot or ankle, because that will internally rotate the hip. So it is safest when a woman actually holds her own legs, because most of the time a woman will not injure her own hip. So if she can give birth holding her own legs without anyone else pulling on her legs, that is the safest technique. It gets more dangerous when somebody else, again, even a well-meaning family member or husband or what have you, pulls on the legs. That gets a little less controlled. So if we can advise women, pull on your own legs, but don't let any other family member or anybody pull on the legs, then we keep them probably safest. And of course, there are alternative birthing positions, and the obstetricians in the audience know these much better than I do, but many of these can help avoid the positions that are going to stress the hip. And again, if a woman is controlling her own position, she's much less likely to injure herself than if someone is pulling on her hip for her. So it's a real honor as an orthopedic surgeon to be presenting at the American College of Obstetrics and Gynecology and to be spreading awareness of orthopedic injuries that can occur during pregnancy and delivery. And working together, we can not only identify these injuries, but in a multidisciplinary way, we can diagnose and treat them and help many women who otherwise may not have found help. Thank you very much.
All right. So now to transition to talk about dreaded liability, something that we all expect to happen and, try to do our best to prevent. So quick poll of the audience. Have you ever been sued for hip-related peripartum pain, either during pregnancy or after pregnancy? Here's our results from the group. As you can see, this is something that is relatively common. In terms of, hopefully the lawsuit isn't common, but of lawsuits, this is something that certainly can happen. Found this quote that we thought was a great kind of way of helping to reduce our concerns about being sued, because getting sued is not necessarily indicative of medical error. 65% of claims closed between 2016 and 2018 were dropped, dismissed, or withdrawn. And those that did go to a trial verdict, over almost 90% were actually won by the defendant. Can be a terrible thing when you get that information that you're going to be sued when someone reaches out to you, but we don't have to totally spiral into a panic. As you can see here, of all physicians, this is not just OBGYNs, of all physicians sued in their career to date, every year from 2016 to 2022 is floating around about 35%. It has decreased a little bit since 2016, but still around 1 in every 3 physicians will get sued in their career. The big table here that parses it out by specialty. You can see at the bottom, the surgical specialties have the highest percentage of cases brought against them, with OBGYNs coming in number one. As we all know, we are the highest physician specialty to get sued. And then this is another slide showing a breakdown by physician specialty. So those that were sued in their career to date, under age 55, were close to general surgery and orthopedic surgery, but still, again, number one. And when that jumps up to over age 55, we are, again, number one of 76.2%, edging out general surgery by just about 0.5% or so. And our patients are seeing that this is an opportunity sometimes. Unfortunately, there are lawyers out there who target physicians, who target obstetricians with negligence suits, with injury suits. You can see Googled liability obstetrics hip injury, and it's just every single thing. And the initial results is all about lawyers that you can contact if you've been injured, if you've experienced emotional distress, reach out to us. And I found this great article, got the link at the bottom, from Contemporary OBGYN Journal. It focuses in the title on urogynecologic injuries, but the body of the article goes into talking about the hip injuries that also happened. And you can see on the slide, it says allegations in this case included negligence in performing a McRoberts maneuver and unnecessary vacuum assisted extraction. So for, related to the hip, McRoberts maneuver is what we're certainly concerned about. This is just an excerpt from the article, and goes into the description of the McRoberts maneuver, a hyperextension of the legs, which led to the hip injury and surgical repair that was needed. At the bottom, there's more detail about the orthopedic injuries that happened, including bilateral labral tears, tear of the ligamentum teres, need for orthopedic surgery, and a litany of other injuries. And it went on in a further paragraph. Thankfully, this case was settled, and there was some probable manipulation by the plaintiff, as she was seen walking around without any issue. But it just goes to show that these are things that lawyers are chomping at the bit to sue us for. So how can we prevent this? As we've talked about, proper birthing support, proper support during delivery is key. Supporting the legs, the knees, the hip, instructing both your nurses that are holding the legs, but also support people, because they're not knowledgeable about this. And, we see time and time again where the father of the baby or grandma to be is wrenching that hip back. We need to be aware of that and help to protect our patients, and help to instruct the people that are supporting the legs. And then documentation. We often in our GYN cases have documentation that says, she was placed in stirrups with care taken to avoid hyperextension of the knee and all that. This should probably be part of our delivery documentation as well, so that we can show that throughout the delivery, there was not hyperextension. There were not certain positions that could have resulted in injury. All right. And I'll hand it back to Dr. Domb.
Dr. Benjamin Domb here from the American Hip Institute, presenting again at the American College of Obstetrics and Gynecology annual meeting here in Minneapolis. And this is a continuation of our presentation on postpartum hip pain, the prevention, the workup, and the management, hearing from orthopedic hip specialists on awareness in the obstetric community of hip injuries that can occur during pregnancy or delivery. My disclosures are listed with the AAOS, and these are the continuation of the case presentations that were introduced earlier. So case example number one, this is a 28-year-old G1, P0, previous Division I soccer player laboring for 10 hours who received an epidural 4 hours ago. Her shoulder dystocia occurred with delivery, and the McRoberts maneuver was utilized with flexion and internal rotation of the hip to get the baby out. and the baby was successfully delivered. At 6 weeks postpartum, the mother continued to complain of right groin pain. She was prescribed physical therapy at that point. Now, a brilliant obstetrician does a physical exam and notices a positive Fader test. Remember, that's the flexion, adduction, internal rotation test. So this one manipulation of the hip reproduced her pain, and this brilliant obstetrician made a referral to an orthopedic hip specialist, enabling this woman to get a diagnosis of a labral tear and impingement and to get the treatment that she needed to get better. Here are her x-rays showing impingement where the ball is out of round, and her MR arthrogram showed a labral tear. She went on to have a successful arthroscopic surgery to repair this tear. Here you see the arthroscopic images of the tear, and we were able to repair this. And here you see the fully repaired labrum after completion of the arthroscopic surgery. Case number 2. So this is a 35-year-old G1P0 woman who is 5 feet tall, and the father of the baby is 6'4". Makes for a great photograph. The patient has diagnosed femoroacetabular impingement, or FAI, and a small labral tear that she's been treating with physical therapy and PRP injections. She presents to discuss options at her 30-week appointment, with the baby already measuring the 95th percentile estimated fetal weight and head circumference. So as the obstetrician, how can you counsel this woman at this point? What can you tell her? The best way to advise this patient is that she is at risk for worsening this hip injury during pregnancy and delivery. And we want to advise her that during a natural childbirth, she can pull on her own legs and try to flex up her legs and hence rock the pelvis backward. But no one else should be pulling on her legs, least of all her 6'4" husband, who should not pull on the legs lest he inadvertently cause a hip injury. So if she's pulling on her own legs, or if a nurse is helping, they're pulling on the thigh, but not pulling on the lower leg or ankle or foot. If they're pulling on the thigh, then they won't cause that dreaded internal rotation, and then she can hopefully deliver this very large baby safely without a hip injury. Case number 3. So this is a 44-year-old G5P4 woman presenting with 5 years of intermittent but increasing anterior pelvic pain and feelings of instability when standing on one foot. Pain started during her most recent pregnancy. She has done pelvic floor therapy, physical therapy with minimal relief. And what we see on her x-ray, if we look closely at the pubic symphysis, is there is arthritis of her pubic symphysis. She's also obviously had a spine fusion, but looking at the central pubic symphysis, we see white discoloration and irregularity and narrowing of the pubic symphysis. So she's actually narrowed the joint because it has become arthritic. And then when she gets an MRI, we see that there is actual bone edema in the pubic tubercles on both sides of the pubic symphysis, which is a sign of this development of arthritis in the pubic symphysis. So the plan then, she undergoes a diagnostic corticosteroid injection in the pubic symphysis. We do these under ultrasound guidance, and that provided her with several hours of full relief. So after she's done with childbearing, she undergoes an arthroscopic symphysectomy. That means we do an arthroscopic surgery and actually remove the arthritic bone plates, but the end plates of the bone at the pubic symphysis to alleviate the arthritic bony contact. So here's the arthroscopic procedure. We're doing all this through keyhole incisions. And before and after surgery, on the left, look at the pubic symphysis where you see this narrowed arthritic pubic symphysis. And in the image on the right, you can see we've created about 1 centimeter of space by removing the arthritic end plates from either side of the pubic symphysis. So there's no longer painful bony contact. And this is a total cure for a woman like this. So again, a real honor as an orthopedic surgeon to be presenting at the American College of Obstetrics and Gynecology. This is a wonderful conference, obviously an incredible culture and incredible obstetric community that's represented here. And I hope that our presentation has had some impact in spreading awareness of postpartum hip pain and injuries that can occur during pregnancy and delivery. Thank you very much, and greetings from the American Hip Institute.
Good afternoon, everyone. Thanks so much for sticking around for this final session today at the annual clinical and scientific meeting here in Minneapolis for the American College of Obstetrics and Gynecology. You might be thinking to yourself, isn't that an orthopedic surgeon up there? And the answer to you is yes. Yes, we have two of us up here, and we are both humbled and privileged to be able to speak with you and to learn from you on this really important topic to us. So we're here to present postpartum and peripartum hip pain, the prevention, workup, and management. Here's the disclaimer from ACOG, as well as our disclosures can be found in the following websites. Learning objectives for today. So after this presentation, you should be able to recognize the most common reasons for pregnancy-related hip and pelvic pain, apply proper techniques and processes to avoid postpartum hip-related complications, develop a diagnostic, management, and treatment plan for patients with peripartum hip pain, and then understand the medical legal liability landscape. So introduction, so we have Dr. Domb here. He is the founder and medical director of the American Hip Institute and the American Hip Institute Research Foundation. I'm Dr. Megan Flynn, an orthopedic surgeon, and I work at the American Hip Institute. And then we have our obstetric and gynecologic really we have our obstetric and gynecologic expert, Dr. Higgins, who has really spearheaded this with us, and we wouldn't have been able to do any of this without her. She is the simulation director at the Cleveland Clinic and a good friend who has been just a wealth of information and knowledge, and I can't thank her enough for this opportunity. So outlined today, I will be going through the prevalence, what happens in pregnancy and delivery that can cause hip and pelvis injury and pain, and also what the OB needs to know in those situations. Dr. Domb will come in and speak to the management and prevention. So what are these diagnoses? What should the OB look for and when to refer? And then what we can do and how to prevent these problems. And then Dr. Higgins will come in and discuss avoiding liability. We'll also have a couple case presentations throughout and at the end. So I'm starting here with prevalence. The first poll we have is regarding how many pregnant patients per week do you see with pelvic or hip related pain? So just trying to get a sense of, in this room, what is the prevalence? How often are you seeing pelvic or hip related pain? So we can go ahead and get started with that poll. A is going to be none, B is 1 to 3, C is going to be 4 to 6, D is 7 or more. So go ahead and take that time, go through that poll. Excellent. So we have, looks like just about everyone has responded here. Thanks so much. And it looks like, 100% of the people have chosen C or D. Most of you, that 70% have chosen D. So this is a very common problem, seems, for patients that you're seeing every week. So that is consistent with what we found in the literature as well. Approximately half of all pregnant patients will experience lumbopelvic pain for more than 3 months. 10% will have this pain throughout their pregnancy, and that pain tends to increase for patients throughout the pregnancy. So the later in pregnancy, the more pain is likely. In the year after the birth of the child, 72% of those pregnant patients will experience pelvic and back pain that has continued past the delivery. Some have persistent pain lasting years, and this can have major impacts on the quality of life for these patients. This disruption of sleep, increased psychological stress, diminishing work capacity, all of these things which are important to that quality of life metrics. So what happens in pregnancy that can cause that antepartum hip pain? A couple of these things, including relaxin and round ligament pain, are things that you as obstetricians know a whole lot better than I do. So I feel a little bit like the student teaching the teacher, but we'll kind of go through a couple of these things. We've got weight gain, relaxin, sciatica, and then round ligament pain. So weight gain, or specifically the recommended weight gain during pregnancy, should be around 25 to 35 pounds. And nationwide, more than 47.5% of pregnant patients had excessive weight gain during their pregnancy. This is back from a study done in 2015. So what is relaxin again? kind of feel like the student teaching the teacher here, so you all know more about this than I do, but it's important to reiterate relaxin is a reproductive hormone. It's produced by the ovaries and the placenta, and it helps to prepare the lining of the uterus for implantation, supports the growth of the placenta if implantation occurs. It prevents early contractions and preterm labor by relaxing the uterine muscles. It also, importantly from an orthopedic standpoint, relaxes the ligaments sort of around the body, not just in and around the pelvis, so that the uterus can expand to accommodate that pregnancy. It can make abdominal muscles more flexible, relaxes the blood vessels to accommodate the increase in blood flow during pregnancy, helps to relax the pelvis before delivery, and also soften that cervix before delivery as well. So these are all reasons that relaxin is important, particularly when it comes to hip and pelvic pain. So sciatica, what is it? This is in the pregnant patient, the weight of the growing uterus and the fetus adds extra pressure to the sciatic nerve, as you can see in these photos, which can cause radiating pain, numbness, and tingling in the hips, thigh, buttocks, and can occasionally go down into the calf and the foot as well. So round ligament pain. So as you all know much better than I do, but it's important to note, round ligaments connect the pelvis to the uterus and support the uterus. As the uterus grows with that growing fetus, these ligaments can then get stretched, causing achiness, sharp pain, and pulling on one or both sides of the body. This is often felt in that anterior hip region. Similarly, during pregnancy, that lumbar lordosis significantly increases, as you can see in these photos. So it occurs primarily in the second and third trimester due to that growing uterus, and the center of gravity shifts toward the abdomen away from the posterior aspect of the body and tilts that pelvis anteriorly. So you can see sort of in this far right photo that increased lordosis of the cervical spine and the lumbar spine increases the kyphosis of the thoracic spine. That increases the pelvic tilt, causing stretching and weakness of the abdominal muscles, the hamstrings, and tightens the others. So what are some of the treatment options for this? It can be braces and physical therapy. So we have this is a specific case illustration. One of our PAs earlier this year was this 33-year-old G3P2 woman at 30 weeks. She reports lumbopelvic pain for the past 6 weeks. She's an orthopedic surgery PA on her feet all day. She was diagnosed with gestational diabetes in this pregnancy, and so far has gained about 40 pounds in her pregnancy. So what was done for her is she was recommended to get an abdominal support garment, also known as a belly band. And there are various styles that are available, as we came to find out, all with varying effectiveness. She chose one that she found on Amazon. It was about $35, and in the next day in the OR, she had a long day in the OR, and she felt so much better after the use of this sort of belly band. Next, there's also an option for peripartum physical therapy. This can include all types of different therapies, as you can see here. And there are other therapies as well. So we're looking at osteopathic manipulative treatments, exercise, acupuncture, we can do Tylenol, heat, prenatal yoga, and stretching. All those things are viable and reasonable to pursue. So what happens in delivery that can cause pelvis or hip-related pain? So again, we'll start this with a poll, a little bit of prevalence here. Have you ever had any patients report hip-related pain from delivery? So I'll give you a minute here to type in your answer. Thanks so much for doing that. We appreciate it. Keep us all awake and engaged. Love that. Okay, so looking at the results here. So 100% of people, 100% of patients have reported hip-related pain from delivery in this, at least in this audience. And then have you ever had to use the McRoberts maneuver? So again, a little bit of time here to input your answer. Great, looks like we have full participation there, and 100%, again, 100% of people here have had to use that McRoberts maneuver. So we'll talk about that in just a moment. But so delivery positioning, the most common delivery positioning is a lithotomy position for a vaginal delivery. In this position, as you are all very well aware, the hips are flexed, and if the patient has an epidural in this situation, they may not be able to feel pain if the hips are hyperflexed and internally rotated. So what happens in complicated deliveries? So shoulder dystocia is when the fetal shoulder does not deliver immediately following the head, and that impacts against the maternal pubic bone. So the McRoberts maneuver, as you can see here, being performed successfully, can lead to, in the pregnant patient and the delivering patient, can lead to lower extremity nerve injury, can lead to symphyseal separation, can also lead to sacroiliac joint or SI joint dislocation as well. So we have an intrapartum case illustration here. We have a 28-year-old woman. She's G1 P0, very first pregnancy. She's a previous Division I soccer player who was laboring for about 10 hours. She received an epidural about 4 hours ago. That shoulder dystocia occurs at delivery, and the McRoberts maneuver is utilized with flexion and internal rotation of her hip. The baby is successfully delivered, which is excellent news. At 6 weeks postpartum, the mother comes back for her 6-week postpartum appointment and continues to complain of right groin pain. At that time, she's prescribed physical therapy. About 6 weeks later, now 12 weeks postpartum, she continues to have that right hip pain, and that brilliant OB does an exam on that patient. What is the OB looking for? Failure, so flexion, adduction, and internal rotation. So you can see that in these photos here where that knee is flexed up to 90 degrees or past 90 degrees. The leg is adducted, so brought toward the midline, and then internally rotated, bringing that foot out. And if the patient has increased pain or that reproduces that patient's pain, you can be pretty sure that that patient has an intra-articular hip problem. So what does the OB need to know in these situations? Continued hip pain and pelvis pain after 6 weeks of conservative treatment could potentially be pathologic. And the exam pearls here is that failure, flexion, adduction, intra-rotation. If that reproduces the pain, it's likely a positive intra-articular finding. So we've got a second case illustration here. This one is particularly appropriate for me. So we have a 35-year-old woman. It is her very first pregnancy. She's 5'0". The father of the baby is 6'4". As you can see in these photos here, this is him proposing. The patient has a diagnosed femoral acetabular impingement, or FAI, which we'll get to in a couple minutes, and a small labral tear that she has been treating with physical therapy and PRP, or platelet-rich plasma injections, and doesn't currently have any hip pain to speak of. She presents to your clinic, the obstetrician's clinic, to discuss options at her 30-week appointment, with the baby measuring at that time 95th percentile estimated fetal weight and head circumference. So the question for us is, how do we counsel this woman and her OB team? So I'm going to pass it off to Dr. Domb, where he's going to take over for the management and prevention side of things. All right, so I'm back up here. Thanks again to Dr. Domb and Dr. Higgins for all of their insights. Hopefully you guys have also appreciated it. So our final poll for today is, go ahead and bring out your phones. So would you attend another collaborative interdisciplinary talk? The answers that you have today, you don't really have much of a choice. Answer A is yes. Answer B is yes, but B. So go ahead and choose your answer. Give you a couple seconds here. Excellent. So we'll bring up those results here. So 80% said yes. 20% of you are being funny, hopefully, but yes, but B. So what are the key takeaways here? Of course, the pregnant patient and the baby, the safety of both of those patients is the primary concern always. So hip and pelvis pain in pregnancy and postpartum can be normal, but pathologic pain does exist. So that's important to recognize those things. The key takeaways in terms of prevention are to avoid severe flexion and internal rotation, so bring those hips up and those feet out. in the lithotomy position, and really want to focus on having that woman in control of her own legs and her own body during pregnancy and during delivery. Also, it's really important to communicate with that patient and document what's going on. And then refer to a hip specialist with experience treating young, active patient population. So here you're going to want to be looking to refer to a orthopedic surgeon with a hip sports medicine background if you can find somebody close to you. So thanks so much again. We really appreciate your time, and we'd love to open it up to any questions that you might have. Thanks so much.